I am delighted to introduce some of the panelists for our panel discussion, and I'm going to ask them to join me on the stage as I mention their names. And I would like, first of all, to ask Dr. Princess Nothemba Simelala, known as Dr. Nono, which is easy for me, thank you very much, who's the Assistant Director General for Family, Women, Children and Adolescents at the WHO. If I could ask you to take your seat, thank you very, very much. Dr. Thomas Palau, Advisor of Global Coordination, Health, Nutrition and Population, the World Bank Group. Please do take a seat. And Dr. Jeffrey Sturcio, President and CEO of Rabin Martin, and hosting the Secretariat of the Private Sector Roundtable, which I think many of you will know. It's a coalition of companies, perhaps your companies, that support countries in strengthening health systems. So we're going to have a bit of a discussion, but we are going to open it up to you and your very informed, no doubt, questions. And I think most probably just to begin, so that we're all on the same page, I would say. If I could just do a quick fire round very quickly, perhaps starting with Dr. Nono, on what is global health security for you and why is it so important?
Well, let me just thank the organizers for inviting me to participate after the powerful input by one of my directors general. For us as WHO, I think Pete has laid it out, but if you look generally at what we're trying to do, is to secure the health and well-being of humanity, as it were, because we can see diseases know no borders, viruses, and all of these pathogens move from place to place. I can imagine, where all of the people who are in this room have traveled from, that it's possible for any pathogen to move from one part of the world to another. It's therefore very important for us to bear these things in mind, that travel these days is no longer safe, and that we need to consistently support countries in ensuring that they can indeed detect, be ready, and respond to ensure that everybody is kept safe. So it's the same thing for pandemics, for man-made disasters, and for everything else. And that's what we're trying to deal with in WHO and with other UN agencies.
Dr. Palau.
Well, thank you. And also, first, thank you for inviting us to be in the panel. We are foremost an economic development agency, so our primary entry point is interest in economic impact, social impact, but also health, as it's integral to the development. Pete Salama already mentioned the human capital. We are making very strong case for the countries to invest into human capital, and health is a very big part of that. In terms of economic impact, we did some analysis after the 2014-15 Ebola epidemic in West Africa. It cost the three countries about $1.6 billion in terms of economic output, and it spread over a little bit to Africa, adding another $500 million in 2015 alone. So, and if you put GDP charts of this type of impact next to the 2007-2008 financial crisis in US, they look the same. So we see that the pandemic risk is in the same league in terms of the economic impact as climate change or natural disasters. So we estimate that moderately severe to severe epidemic would cost about $600 billion, about 0.7% of global GDP. And if a Spanish flu were to repeat today, it could be as much as 5% of global GDP. So we see our role in making really economic case for the ministers of finance to invest in health security and actually keep it going through quiet times. So, so we convened this international working group on pandemic financing a couple of years back, and that was shared by another Peter Sands, who is currently head of Global Fund. And this produced a report that it was titled, I think appropriately, From Panic to Neglect, Panic and Neglect to Sustainable Financing of Health Security Panic meaning countries spend a lot of money when there is a crisis, and then neglect it through the quiet times. So why not to make a perfect economic sense to sustainably invest it from year to year? So that's our entry point.
Certainly, yes. Dr. Sturcio.
Well, I would just add that I think both Dr. Similala and Dr. Paolo have talked about some of the consequences of global health insecurity. Mm-hmm. And so if you flip it around and just think for a minute, what would global health security be? I just want to play off what Dr. Similala said. It's the condition in which people can be assured of being able to live healthy and productive lives. And what that requires are the kinds of investments that Dr. Paolo talked about, so that ministers of finance may not be experts in understanding the intricacies of epidemic response, but they certainly understand that the investments that lead to sound economies, to stable economies, to productive economies are worth making. And some of those investments have to be investments in health infrastructure, and in the ability to prevent, to detect, and to respond to health crises and epidemic threats as they emerge. So the work around global health security is to ensure that we can prevent, detect, and respond. But it's really all in the service of ensuring that that people have the ability to protect themselves and to live healthier and more productive lives.
Mm. And as you were saying, Dr. Nono, that's all about having this foundation of a resilient health system. And I was wondering, from your perspective, what does a resilient health system look like compared to a non-resilient one?
I hope we don't strive for non-resilient systems wherever we are in the world. I have an issue with this word resilient, because I think it takes the focus away from, once you say resilient, I think ministers or heads of state or anybody who's responsible for the well-being of citizens starts to think, oh, I've got a big problem. But in my view, if there is systematic investment in the most basic systems that respond to people, and I think that's what Pete was talking about, these numbers that we churn out all the time, these are human beings. These are people who are alive, who really have the right to health and access to the best. So if governments were to look at that investment from the outset, a woman in a village has to have access to a clinic that's functional, that's got a healthcare professional that knows what they're doing, that's got the medicines. If you do that, even just with immunization and basic health care for women who are pregnant, you're already investing 1,000 and 1,000,000 times more than what you'd need if there's an outbreak. So the conversation does need to change. But I feel the conversation doesn't need to be confined to ministries of health, ministers of planning, water, sanitation. These are people who must come to the table. And I think that's what we've missed as global health advocates, is that we are consistently running to the same ministry. And the Minister of Health doesn't decide how much carbon emissions are going to be in the air. Ministers of Energy. So I really believe governance and governments must plan differently. This vertical planning is not going to provide us with sustainability.
And for you, the focus is really on primary healthcare and community healthcare.
That is the foundation for universal health access, because by the time you get to the second and third tiers of healthcare, it means the primary system has failed. So prevention and promotion, these are cheap interventions, as it were, compared to expensive interventions when people have failed in the system. So that is the foundation. But what you've got, if it's covered, and then when people don't respond, then you need more sophistication. But I find for many diseases, even the NCDs, people, if they are empowered, have the ability to prevent these things. It's about eating well. It's about healthy lives. But if we don't make healthy choices easy for poor people, then we have a problem. And that's what I think governments need to address, and we collectively, as partners, should support them to do.
And what can be done, because Dr. Salama was mentioning the 20 to 30 countries, the fragile states, many of which are in conflict, which is where 80% of these infectious outbreaks actually come out. What can be done to address the needs of the people who are extremely vulnerable in those contexts, contexts like we've heard in DRC?
I think much more than what is being done. Already, as Pete has explained, the world is responding. But much more needs to be done in understanding the context. Right now, you've got conflict, and that's man-made. I mean, it's not an utopian thing when I'm trying to say we're responding to things that governments and countries can prevent. Why is there a conflict? I mean, it's costing everybody so much resources. But we can't do that as global health advocates, but we can continue to advocate for that. There's much more we can do. We can invest in the very people that we are trying to help. I believe that is more sustainable. And Pete might have highlighted that in these countries where there is protracted crises, we often find that communities find a way to become resilient. And we need to invest in people. People need to know. Much of the things that go around in parts of Nigeria, for instance, we're not reaching coverage with immunization. We can't call it vaccine hesitancy, as it were, but it's because people don't know. They don't have the information of how important it is to take their children for vaccination. So you deal with the myths, you deal with the suspicions, but you use community people to do that. Because people also have an aversion to people coming in and leaving, and prescribing what they should be doing.
It's about persuading the communities on vaccines, and as we know, there's a big anti-vaccine lobby everywhere, but there's a lot of suspicion in these communities too about it, and use them as a resource. I was also wondering is it something that vexes you that there are barriers to sometimes in the regulations in these countries of getting drugs in? I know that this has been one of the issues, I think, in DRC with Ebola, and what can be done during an emergency to make sure that the drugs and the vaccines get to the people?
I think the work that's been done with the health authorities is important. When the ministers are here, for instance, for a World Health Assembly, and we talk about movements of people across borders, part of what needs to be done is to ensure that there are no regulations, especially in host countries, that prevent any commodities. I mean, my area of focus is women and children. And most importantly, we need to get commodities for safe abortion services across borders. If a country has a law that says abortion is a criminal activity, or providing those services is not according to the law, often we do get blocked in that you can't then get the drugs, mifepristone, misoprostol across the border, manual vacuum aspiration kits and things like that. But the women in the camps, they are being sexually assaulted, they are being raped, they are experiencing all sorts of trauma, which is often not part of the initial response. Often when there's a humanitarian response, it's all of the things that Pete spoke about. But the needs of women in these camps are often forgotten. Women give birth in really bad circumstances. And if you look at the numbers of young people in these circumstances, they are growing year by year. And if we want to invest in the future, we must ensure that women and children in these settings get the services that are the best given the circumstances. And these services are not complicated. As I said, immunization, the provision of a family planning commodity, these things can be done.
And we could even broaden it, I suppose, in protracted crises, ones which are 5, 6, 7, 8 years long, there's the issue of mental health, which is also part of your remit. So it's, as you say, it's not just responding to the emergency, but people are living in very difficult situations, and they're good people who need to be enabled to help themselves. Yeah, interesting. Thomas, if I could just bring you in there on barriers, because I suppose we often think that the barriers are financial ones, and I was wondering whether you could illuminate for us what the World Bank is doing in trying to make sure that there's adequate financing when there is an outbreak, during the response, and perhaps also at the preparedness stage.
Right. We yes, we are not a public health agency. We have very few epidemiologists, so our angle to it is systems and financing. And of course, it would be good to unpack a little bit what does it mean to finance preparedness or health security, because it is complex. It is linked to the health system, for very much the front line, how the front line works, because surveillance, first line response is there, labs, access to essential medicine should be there. It's also on the animal side, linked to the animal health systems. And of course, when we also link it to disaster preparedness, all countries have disaster preparedness systems. So how to put epidemics or pandemics on the same footing as other disasters can strike. But first, I would like to say that there is really strong case for the government to finance it appropriately as a public good. It's also in sense that the international community takes strong interest, especially in fragile settings that have been already mentioned, because it's also international public good. And as Pete Salama says also, I think private industry take interest and attention because ultimately we are all better prepared. But when we try to unpack this financing, what does it mean? And I think it's part of it is kind of regular, recurrent financing of the front line of the health system and animal health system. So later on I say, well, we have done some work, so how much does it actually cost? What does it take? But then there is also investment cost and startup cost. Pete didn't mention, but there is this initiative that countries actually assess their capabilities to be prepared, called joint external evaluations. That's done together in countries, but also independent internal experts. And it's like 19 domains for different dimensions of preparedness. So once they have it assessed and the scores range from 1 to 4, then they need to come up plans how to improve, go from 2 to 3 or 3 to 4, or maintain even 4. That requires some sort of investment and startup cost. And I think international community really should take note of that and help to finance that. Recurrent cost should be really domestic responsibility. And then the third dimension is the surge financing, what you really need and how you are prepared when something like in DRC strikes. Domestically, I already mentioned link to the disaster preparedness, disaster management systems in country, but also internationally. Here, the World Bank helped to put together something we call, again, in partnership with private sector, Pandemic Emergency Financing Facility. That is an insurance-based arrangement, so that and why we did it? When 2014-15 Ebola epidemic happened, then we realized later on when we did that analysis that it took about 6 months for the international community to mobilize. Because go to internal procedures and bureaucracies and figuring out how much and where. So the idea of doing the facility was born, and I think this facility can, in principle, once conditions are met, for the insurance window, it is when WHO declares it as a public health event of international concern, then these resources can flow immediately.
And what diseases are there? Are there specific diseases?
Yes, I think there are specific pathogens mentioned. So it is not good for the flu, but it would be good for Ebola. It hasn't been triggered this time because this has not been announced yet as an international event. And also there is a condition that at least 2 countries be involved. But there is also cash window, what we call when can be activated earlier. This is funded by donors, and this has been activated in case of the DRC, the 9th epidemic, but also carrying over to the current outbreak. But I also say that we also reconfigured all our portfolio by including all our new operations include what we call a CERC component or zero-cost component. So we put into original design a component, CERC means conditional emergency response component, that would allow from any project in case of emergency very quickly reallocate resources to emergency needs. No need for negotiations or new financing agreements. And this we have also triggered in DRC case, so it's been providing quite significant financing for the emergency response.
And if these hadn't existed, and we've got the PEF, the Pandemic Emergency Financing Facility, they all have such easy names to say. But if we had had that before the Ebola crisis, what difference do you think it would have made?
Original one?
Yes, the one in West Africa.
The funds would have been there 6 months earlier. That would have allowed for quick response. I have to say that it also comes with some expectations that it's not just money. Countries need to have plans ready so that they can actually finance something, that it's too late to start planning when event happens. And they need also to have what?
I can hear you beautifully, but...
Okay. I see.
There we are. Everybody has to speak a little bit louder, I think, because of this venue.
Thank you.
Yes. Yes, indeed. It would have been there earlier. And you were mentioning these massive figures that were actually spent in the end on Ebola response. And it might have reduced some of those amounts because we'd have tackled the crisis earlier.
Perhaps I also promise to say, so what does it take and what we have found? How much does it cost to be prepared? And it turns out it doesn't cost that much. We did a quite in-depth study in Vietnam. I looked at the 2016. That was a quiet year for Vietnam. So we concluded it cost about $2 per capita for them to maintain preparedness for the pandemic threat or the endemic threat. So, then the question, they did their own evaluation, and it also turned out that they are weaker in some areas, stronger in other areas. And so then they went to next phase, and I think that's where also the World Bank is involved, helping them with incremental costing. So how much does it take to improve your preparedness? And in Vietnam case, it turned out to be about 30 cents per capita to address what they said about 118 broad actions to improve their preparedness. It's not also astronomical, so it really requires Ministry of Finance to allocate this money and make this work. And also, perhaps important for this audience is we did 2 simulations. One is what it costs to also with stockpiling some emergency the medicines for the response, and that would increase in Vietnam case to about 70 cents per capita. So, but also not astronomical figure.
Indeed, the economic arguments that people need to go with to the ministries in these countries, as you say, that the costs are not astronomical, but they need to find some money from their budget. Dr. Sturcio, if I could bring you in, because I introduced you as hosting the Secretariat of the Private Sector Round Table. So perhaps you could give us some ideas of how the private sector can be involved in preparing and reducing global health security.
Sure. Well, Dr. Palu mentioned the joint external evaluations, and that's an element of the work that the Global Health Security Agenda does. So let me just step back for a moment, and then I'll come, that'll provide the context to respond to the question you just posed. The Global Health Security Agenda, it's a somewhat confusing name because it's both a policy agenda and a coalition of about 70 countries that are working together to help ensure that most countries are better prepared for health crises as they emerge. And what the Global Health Security Agenda has done, it was founded in 2014 in the midst of the Ebola outbreak in West Africa. It was led by a small group of countries, the US and a couple of other Western countries, but it also involved Indonesia early on and a number of other countries that have since become leaders in this effort. And the idea was to help ensure that countries could prevent, detect, and respond to either biologic threats or pandemics or other health crises as they emerge. So one of the ways in which this group of countries collaborates is by, they've created the JEE Alliance, the Joint sometimes when I come to meetings like this in Geneva, I feel that I'm playing acronym bingo.
The joint evaluation.
The joint external evaluation analysis. So I'll try to stop using acronyms and speak in plain English. So that's the effort to coordinate these analyses of the health systems in different countries to find what gaps they have in whether it's in infrastructure, in workforce development, and other areas. In addition to doing those analyses, which provide a roadmap for the changes that governments would have to introduce to ensure that they're better prepared for health emergencies, they also have created a set of action packages. And these are 11 different areas that range from supply chain and logistics through workforce development to technology and data analytics, to the capability to deal with antimicrobial threats, financial processes and analytics, the kind of background to the work that the World Bank has done, as Tomas was talking about, public and risk communications to ensure that the public understands the challenges and what capacities are there to help them and what they can do, and also corporate health offerings, because in many countries, the health system, the public health system, may have gaps, but there are often private healthcare resources that can be used as well. So the combination of the JEE, which provides, I just did it, I used an acronym, the joint external evaluations, which provide a roadmap to what needs to be done in each country, plus the action packages, which are collaborative efforts to address those concerns in individual countries, really provide a framework in which the private sector can begin to collaborate with members of the Global Health Security Agenda. So in 2015, the Private Sector Roundtable was created at the instigation of the chief medical officers of Johnson & Johnson Global Public Health and General Electric's healthcare business. And it's a group of companies that have come together to work with the GHSA, I did it again, the Global Health Security Agenda, to really take the capabilities that the private sector has and the interest that they have in ensuring that the health systems in the countries where they operate can deal with crises, to ensure that we bring all of these resources together to come up with more stable, more secure health systems that can address the range of concerns that may emerge. Another point that I would just add is, one might ask, well, why is the private sector interested in this? Aren't these challenges that organizations like the World Bank and the WHO and national government should deal with? Well, yes, those the governments and multilateral organizations have the primary responsibility in this area, both for addressing how health systems will operate at the country level, in financing those health systems, and in providing the normative guidance to inform the work that the countries do. But at the same time, the private sector is present in these countries. The private sector lives there, they have employees and their families there, they operate in communities in those countries, and they also have capabilities and resources that can be put to use in helping to ensure that countries do a better job of responding to health crises.
Could you give an example, perhaps? Or?
Oh, sure. Well, a number of examples. One that comes, a well-known example that comes from the West Africa Ebola outbreak in 2014, 2015 is that Bridgestone Firestone, which is a tire company, so you wouldn't think that they have any special expertise in health, actually has a large rubber plantation in Liberia. And as a result, there were about 80,000 people who depended on Bridgestone Firestone for their routine health care. And during the Ebola outbreak, Bridgestone Firestone had a network of clinics in the plantation, the area where those 80,000 people lived, that were actually able to be made available to the broader community. And Bridgestone Firestone had, the protective equipment that was required for health workers in those facilities in that situation. And so they were able to work very closely with the government and with WHO and other external partners to help ensure that more people got adequate care and treatment during that Ebola outbreak. So that's one good example of how a private sector company, which was in Liberia for reasons that had to do with its core business, was actually able to use resources that it had developed that complemented the resources that were available in the public sector. Another example, a good example from the GHSA, is that A couple of years ago, the ministerial meeting of the Global Health Security Agenda was in Uganda, and the health minister of Uganda invited the private sector roundtable to work with them to help Uganda address the gaps that were discovered through the joint external evaluation of Uganda. And so members of the private sector roundtable have made a variety of efforts, for instance, to second people who were experts in economic analysis, in communications, and other skills, where the health ministry felt that they needed those skills to be able to respond more effectively to the challenges that they had identified. And also another private sector company has provided management development training, again, to help the cadre of managers in the Ugandan health system to be better able to cope with the range of issues that would come up. And they've also provided training modules in areas like how to diagnose resistant microbes to deal with AMR or antimicrobial resistance, or how to manage the laboratory facilities that are required to test for the various pathogens that create certain health crises. So there's a good example of how the Ugandan public sector is leaning on the private sector roundtable through these kinds of examples to help them build the capacity they need to more effectively deal with health crises when they arise.
And I'm just wondering, though, are they quite slow, though, some of these Ministry of Health, to actually realize the role that private sector can play, whether it's pharma or whether it's these other industries that you mentioned? Are they a little bit concerned that there might be a conflict of interests, for example? And there's a lack of trust there.
Yeah, well, that's, and Thomas Cooney alluded to this in his remarks. Peter Salama alluded to these questions as well. And yes, I mean, it would be naive to think that there is perfect trust between the public sector and the private sector on all issues. There are certainly, there have been occasions where there have been issues that really reinforce the reasons why people may not trust each other. But let me just generalize this. I mean, it's, conflicts of interest are often seen and discussed as though only private sector enterprises have conflicts of interest. But everybody involved in global health has interests. Governments have interests in making sure they have the money they need, and they have interests in structuring their system in a particular way. The WHO and the World Bank have interests in the role that they play as multilateral organizations in these systems. And companies have interests as well. They have business interests, but they also have interests in making sure that the environment in which they operate is one that's conducive to doing business. And global health threats really just make it impossible for day-to-day commerce to exist. There are the challenges of sick employees and supply chains that break down, and those create challenges for business to do what it does. What's important in these circumstances is to just be clear about the common objective that you're trying to address.
As Dr. Salama said, it's about win-win and it's about shared interests.
Exactly. So, one doesn't have to agree on everything. One doesn't have to have the same interests as your partners, but you can agree on something that you want to fix. And we've been talking about fixing weaknesses in health infrastructure, fixing gaps in the health system in countries that are under threat or could face health threats. And those are areas where you can identify a common goal, where you can bring complementary resources and capabilities to bear, and agree that you will work together to achieve the targets that you've set out, which will have an impact on improving health outcomes when health threats arise. And that's good for, well, as Dr. Salama said, a safer world benefits everyone. So it's good for business, it's good for the country, and it's most importantly good for the people who live in that country, because they'll end up having healthier and more productive lives.
I was also struck by what Thomas Cooney said, and also Dr. Salama, about, they used the word transactional and wanting to move from this transactional relationship to a true partnership. I mean, perhaps I can ask you, and then perhaps the others before we move to questions. What is the key to actually effecting that shift from this perception of transaction to true partnership?
Well, I think part of it is, and this is going to be, it's not a, not a blinding insight. It's something that's actually quite obvious. That if you begin to work together in these kinds of partnerships, and we've talked about a number of them today, then that breeds trust, and that leads to further collaboration, and that then leads to even better trust and an opportunity to do more together. So I think part of it is just the need to begin to find ways to work together and then to build on what works, and to really then try more ambitious ways that you can build global public goods through that collaboration. You know, I've been working on these issues for over a quarter of a century, and many others here have as well. But it's really been encouraging to see the way in which the relationship between the private sector, whether it's the pharmaceutical industry, the oil industry, or any other business sectors that are involved in lower and middle income countries, it's really been encouraging to see the way in which the relationships between the private sector and the public sector have evolved over that period. And I think through the examples that everybody has talked about today, and also this morning in the work around Access Accelerated, we really see that there are efforts to find ways to work together and to really end up with doing more together than any of the partners can do on their own.
Yeah, sure. Dr. Nuno, I mean, with the private sector, and what would you like them to do more of?
Sure. The private sector is already front and center of the UHC agenda. I don't think there's many countries, and here I speak about middle-income countries, low-income countries, that can achieve the UHC agenda without the private sector, be it pharma or be it others who will assist them to build the systems. And I think, maybe I'm a bit naive in this space, but I've seen so many examples of public-private partnerships. In my previous job, I worked in South Africa in the Office of the President, but the ministers of trade and industry have no such aversion to the private sector, to be honest. What we really need to do is to bring an all-of-government approach to look at those win-win situations. So for many of these countries, the private sector is so ahead in terms of the provision of high-quality services, and to bring the public sector onto the same level of quality, you will need support from the private sector. You will need those engagements. You will need pharma right in the middle. And it's our job, I think, as agencies to foster those relationships. Indeed, there's always going to be suspicion or whatever, but you've said it. In every space where we are all competing for more or less the same things, there will be those kinds of relationships. But if WHO can work with the pharmaceutical industry, governments can do that. And I think many of the things that we've discussed, that Pete has raised, there are many threads, from the global health security assessments. We use those for UHC. So if you flip it for the minister to say you are not only just preparing for an emergency, you are actually building your own system, they get a better understanding of why they need to invest. And through many of the interactions, for instance, Gavi, once the blueprint has identified the pathogens, there's a big vaccine investment strategy that's led by Gavi with WHO and many other partners, including the donors that fund like the polio eradication initiative. So our paths cross in many spaces, and all we need to do is adhere to the rules, for instance, that guide how we as WHO can engage with pharma. But ministers are following, I think by embracing the UHC agenda, they are invariably agreeing to work more closely with the private sector. So I don't see how we can drive this agenda without the presence and support and collaboration of the people in this room. We rely on them to make those innovations because, for me, my preoccupation is women and children, families and adolescents. I need commodities that a young girl, whether they are in the city or in a village, can be able to use. Point-of-care diagnostics, things that empower people and rather not depend consistently on a system because there's an opportunity cost to get to a clinic. So what can we do? Social media and all these new things that people have, those we can use to send messages, to ensure that people are really empowered. So I see these relationships continuing to grow exponentially, because there is absolutely no way that lower income and middle income countries can finance all of these things that their countries need. Indeed. On top of the health, it's education, it's jobs, it's housing. There's much too much, you know. Yeah. And I think they should be more open. And I see, as what you have observed, an increasing embracing of one another. If there is a common agenda where they see a win, I don't see how they can consistently be holding back. So let's break those barriers and bring people together around the table to look for common solutions.
Thank you. Let me go to the people in the room then and ask whether you would like to ask questions of the World Bank and its financing proposals, the private sector roundtable. We've seen that there's some unlikely partnerships with many different companies and not just pharma in responding to epidemics, or whether you have a question for Dr. Nono. Yes, there's a gentleman in front of me who has his hand up. If you'd like to say who you are and who you'd like to answer your question.
Yes, I'm Gerald Yonga from NCD Alliance, East Africa NCD Alliance. My question is actually a bit general, so any member of the panel can take it up. There's this complex relationship between political crisis in vulnerable countries and economic crisis and diseases, especially infectious diseases such as Ebola, to mention just one. When we talk about emergency preparedness, and we have this political instability that makes certain vulnerable populations much more affected, and also which makes control of diseases very difficult, I wonder what mechanisms WHO and other global players and governments and global partners are putting in place to address both of these factors simultaneously, given their complexity in nature.
If I understand the question, yes, perhaps Dr. Nono, it's about the fact that, yes, it's the perfect storm. It's these complex relationships, especially in these fragile states. So what mechanisms does WHO have when you've got this particularly difficult situations? Yes.
I think in recent times there has been a huge and very emerging conversation within the UN. I think it's a couple of years old, talking about the nexus between humanitarian issues, development, and peace. So I think there is something that people are alive to the nexus between all of these things, and are trying to find ways in which we can deal with a humanitarian situation, focusing also and ensuring that you can also sustain development. And I think that's why the package that is being sent out, or at least provided to support these countries, is so complex. We're now no longer just responding with bringing, you know, emergency relief. We're now looking at nutrition. We're now looking at other diseases, and we're looking at how do you then assist those governments or those countries that are in conflict with one another to at least achieve some level of stability. These are not easy questions, but by ensuring that we can go in to spaces where there is a crisis, as WHO, as UN agencies, it means those conversations are allowing access. I mean, Pete didn't have an opportunity to talk about those places where his team works, in Syria, for instance, where they sometimes are blocked from going into those places. So these are day-to-day challenges that forever come up. And I think there are mechanisms within the UN system that are starting to open those spaces. But at the end of the day, I think there are governments and leaders that must take responsibility to make the right decisions about how we bring an end to most of these conflicts.
So it's connecting the efforts between the humanitarian community,
Precisely.
the development community, and even the peace-building community, yeah, which actually can sometimes play a role in getting access to the humanitarians. Yes.
Yeah, let me just add, I want to come back to another comment that Peter Salama made earlier, which is that, as he said, primary health care is our first line of defense. And I think that this also links global health security, what we've been discussing in this session, to the universal health coverage session that's coming up. Because you know, the kind of complexity that you were talking about and the many challenges that governments face, particularly in fragile states or with vulnerable communities in other countries, you know, the solution to those problems is the same set of issues that we've already talked about. It's having a strong primary health care system. It's making sure that the health infrastructure is adequate to deal with the range of challenges that a government faces on behalf of its population. Having an adequate health and trained healthcare workforce. Ensuring that you have the right level of leadership and governance in the healthcare system. And those are the common foundational elements of both a strong response for global health security and a strong foundation for universal health coverage. The other thing I wanted to just allude to, and I wanted to come back to the question you asked earlier about non-communicable disease, because we spent a lot of time talking about communicable diseases and pandemics and other health threats. But you know, I just did a quick calculation. Thomas Cooney reminded us earlier that roughly 38 million people a year die from the major non-communicable diseases. That's almost as many people die every day from the major NCDs as died in the entire Ebola outbreak in 2014, 2015. Right? It was around 11,000 people, and it's roughly 10,000 people a day who die from NCDs around the world. So the question to ask is, you know, shouldn't we be thinking of that, of NCDs as a global health emergency and a question that leads to insecurity and instability in the countries that are most affected by those diseases? I think the answer is yes. Georgia Lane wrote a commentary with a colleague in the Bulletin of the World Health Organization recently making that case. But you know, it's not to say that we want to just add yet another set of issues to the long list of issues that Peter and Nono and Thomas and their colleagues deal with. It's to go back to the fundamental questions around building a strong health system, and then that provides the resilience, to come back to a point we made earlier, that enables countries to respond to whatever challenge they meet. So I think that's something that, you know, the reason that the companies in the private sector roundtable are working closely with the global health security agenda is to be able to contribute the capabilities and resources that they have to help governments implement the plans, the roadmap that's been made clear from the joint external evaluations, and to be there to support those governments, because it's important for them as businesses, just as it's important for them as citizens of the countries that are affected by these issues.
Indeed, yes, please.
So I bring together the political question and also the partnerships. Under my other hat, I'm also representing World Bank in a partnership called Universal Health Coverage 2030. And we're very happy to welcome private sector constituency to that. And we will have a steering committee in New York just in 1 week's time, and expect private sector constituency to be there, building trust, understanding better each other. This is the first task. But it's also a political platform, advocacy platform. Fragility is one of the themes. Taking it to the international action, the last United Nations General Assembly, there was a call to action on universal health coverage in emergencies, putting force behind that. There will be another high-level meeting next UNGA, which is on universal health coverage. So how to build this political commitment behind that, including the international community support into these fragile settings, because these countries cannot, very difficult for them to mobilize resources and also sometimes deliver services, because governments often don't control parts of the territory, and what kind of partnerships you can enter to. And finally, we have this DARES framework, which it also calls for better collaboration by international agencies in these countries to help with this challenge.
So I think to answer your question, yes, there is concern about NCDs, and we're going to be looking at that in the next panel after the break. Just before we go to the break, let me ask the audience whether they have any more questions for our speakers. I can't see anybody's hand going up, but the light is really in our eyes here, isn't it? So it's difficult.
The one in the front corner.
Yes, please.
I have
please say
a
your
question.
name and who you would like
Angela
to.
Kalim, Director Communications for IFPMA. And my question is related to vaccines and what Dr. Similala spoke about earlier. And the question is about the fact that, we are seeing an increasing trend where the essential 5 vaccines, which are crucial during the childbirth and right after that, we are seeing a trend where in the developing world, the trend was decreasing due to access, but in the developed world, we are also seeing increased cases of rubella and measles. And is that not qualify for preparing for emergencies? And is that something that are we looking at before these are become full-blown emergencies? Thank you.
Yes, please.
Yes, we are very worried about those diseases. And once we see a spike in any of them, we consider that a problem because of the challenges. You talk about measles. My book says measles moves fast. We must move faster. So it is a crisis. It's a problem. And it's really associated with quite a number of things we're seeing. Large movements of people, as I said, a lot of undocumented people, children who don't receive the full range of immunizations that we're looking for. They don't get boosters, and urban populations that are hard to reach. And those are things that in the immunization program we have identified as crises, as emergencies. As you may know, we do have an elimination goal for all the regions. With Venezuela now, they've lost that elimination status that they had. When we go back to the World Health Assembly, we will retable a lot of these issues because we are now working in a very complex environment, whereas before we could predict that a country could do X, Y, Z, and you'll be able to eliminate a particular vaccine-preventable disease. These days, we cannot be so sure. The epidemiology is changing, and people, as I said, are moving all over. The interaction between humans and animals is closer, and the movements of people from villages into the city. There's so many challenges, and which really require what we're working towards, drawing from what Pete said, just for routine, an integrated surveillance system that will allow countries to be able to track. And that means there should be an ability for countries to provide us this information. Some countries don't want to share. Some are really concerned about security for their own citizens. So there has to be a social compact around this if we really are to achieve a completely safe global environment. And these are negotiations that are ongoing to ensure that wherever people move, we are able to say, here is where there's a threat and where there is a possibility of something happening. So all of these challenges all the time bubbling, but indeed we're keeping an eye on measles and rubella.
Okay. And if I could take a question from the front row.
Thank you. Dr. Nono, Lydia Ogden with MSD. I wonder if you could talk a little bit and follow on about the particular role of vaccine confidence or lack of confidence and how WHO and other public health authorities and the private sector can work together to address that problem.
Wow, that is becoming a huge challenge. You've got two sides, which I tried to mention earlier. I use Nigeria because we experienced that with just our immunization program. And the south of Nigeria is very different from the north. And you find that there are communities that are embracing of these interventions, but you make more headway if you use communicators from within the community. And then in the developed world, you are having a lot of vaccine hesitancy. And we have placed a red spot on that. There'll be a big summit in Europe next year where we will participate and work with the European region to deal directly with the issue of vaccine hesitancy. We're working with the professional associations, the people who train OBGYNs, health workers, nurses, who sometimes do become the source of generating this hesitancy. We're working with parents. We're looking for people in the private sector who are good communicators. I believe health professionals are not good communicators. We need those marketing agencies to come and assist us. And we believe that also working in schools and empowering young people and their parents is on the agenda. So that's one of the big things that's emerging that we really are very concerned about, resistance to uptake of something that is really so useful as a vaccine.
Yes, indeed. I would like to encourage those who still have questions to perhaps ask the questions over coffee, and because Dr. Nono, Dr. Paolo, Dr. Sturcio will be with us for the rest of the afternoon, and we're going to take a coffee break now and come back at 4 o'clock. Please do use it to network with all of the different organizations, the industry, the international organizations, and the NGOs who are here. Thank you very, very much.
Thank you.